there was a class about tuberculosis, basics of TB, right? So first, let's recapitulate my previous class, okay? So here are some MCQs. The first MCQ is, which component of cell wall of Mycobacteria facilitates survival bacilli within the macrophage? এই ক্লাস করতে গেলে গল্প করবি না আর ফোন রাখবি, ঠিক আছে? ফোন নিয়ে ক্লাসে করা যায় না, যে কোনো একটা করতে হবে। সো হুইচ কম্পোনেন্ট, শুনতে পাচ্ছিস ঠিকঠাক? হুইচ কম্পোনেন্ট অফ সেল ওয়াল অফ Mycobacteria facilitates its survival of bacilli within macrophage? And options are peptide. Which is the answer? Which is the answer? Lipoarabinopyrin is the right answer. Mycolic acid doesn't facilitate Mycobacteria survival within the macrophage, but it provides acid fastness of the Mycobacteria. Whether lipoarabinopyrin, peptidoglycan and arabinogalactan, these three components are the core components of the cell wall. They are the lipids of cell wall, but the lipoarabinopyrin is the one that facilitates survival of the bacilli within the macrophage. Which is incorrect about Mycobacteria? It is circular in shape, it is non-spore forming, it is anaerobic. All are correct. There may be multiple options as well. Multiple options. A and D. So D means all are correct. So why should you tell A? A and C, yes. It is slender bacilli. It is thin and slender. It is not circular shape. And it is aerobic. Uses oxygen and liberates carbon dioxide. Which is not an acid fast organism? Is it NTM or Mycobacteria other than tuberculosis? Is it Nocardia? Is it embryophore of Tinea saginata or Tinea solium? Which one? Solium. Solium is the answer. Solium er hoy na acid fast. Baki saginata er hoy. Ar ki organism ache? Actinomycetes, Cryptosporadia, Isospora. ঠিক আছে? Which is not true? Secondary TB affects predominantly upper lobe of the lungs. B is the miliary TB, mostly localized to upper and middle lobe. Ghone's complex includes paratracheal lymphadenopathy. I must say this is not lymph node, this is lymphadenopathy. And B and C, which is not true? Which is not true? Which is not true? What should be the answer? D means B and C. Miliary TB mostly, so সবার একই answer B and C. D is the answer. The correct answer is only B, because Ghone's complex also not only includes hilar lymphadenopathy but also paratracheal lymphadenopathy. So, but in case of miliary TB, because of its hematogenous dissemination, the lower lobe is the mostly affected. But actually, miliary TB affects the whole lobe of all the three lobes of the lung and two lobes of the left lung. But the mostly localized part is the lower lobe because of the hematogenous spread. What is the annual chance of reactivation of TB in case of people living with HIV? Is it 5%, 10%, 30% or 50%? ক্লাস করেছিলিস আগের দিন? আগের অনেক দিন হয়ে গেল, 2 months back করিসনি ক্লাস? 10% is the answer. আগের ক্লাসটা না করলে এই ক্লাসে কিছু বুঝতেই পারবি না। আগের ক্লাস বেস ছিল, বেস অফ দ্য টিউবারকুলোসিস। তো দিস ইজ অ্যাডভান্স অফ টিউবারকুলোসিস। কি করে বুঝবি? কি পড়াবো তাহলে? এগুলো অ্যান্সার ঠিকঠাক দিতে হবে। And if the patient is not living with HIV, that is normal population, the reactivation chance is less than 5% in 5 years, in 1 year, right? And 5% in 5 years. And in case of PL-HIV, people living with HIV, the chance is bit higher. It's 5% annually in 1 year. Okay. Most common involved group of lymph node in lymph node tuberculosis. Is it occipital, submandibular, submental, or posterior cervical? Posterior cervical is the right answer. Another one is, another one. This is not, yes, cervical group of lymph nodes. This is not in the option. Another one, supraclavicular. Supraclavicular is another one. Posterior cervical and the supraclavicular group of lymph nodes. Occipital lymphadenopathy mostly reactive. They are because of the hair problems and scalp infections. They are mostly localized infection. Submandibular is also localized due to localized infection of the submandibular gland, also tonsil, and same as for submental. But in case of disseminated infections like tuberculosis, like other bacterial or viral infections, the mostly lymphadenopathy, mostly enlarged lymph node groups would be posterior cervical, followed by supraclavicular. And what are the characteristics of lymphadenopathy in case of tuberculous lymph node? One and only matted. Matted তো অনেক কিছুতে হতে পারে। ক্যালসিফিকেশন হাত দিয়ে বুঝতে পারবি? হাত দিয়ে মানে জাস্ট বাই প্যালপেটিং দ্য লিম্ফ নোড, হাউ ক্যান ইউ? Mostly not solitary, mostly multiple, mostly they are matted. Next, size is bit less than 2 or less than 2 to 3 centimeter. And in case of advanced lymph node tuberculosis, there would be a discharging sinus above the lymph node. So you can collect the pus from the sinus and give it to a culture or microscopy. You know pot spine? What is pot spine? Pot spine. What is pot spine? Spinal tuberculosis, right? Pot spine most commonly seen in upper thoracic vertebra, upper lumbar vertebra, lower thoracic vertebra, or lower lumbar vertebra. If you choose two correct options, so two, upper lumbar and lower thoracic, and only one option, C greater than B, that is lower thoracic first involved, then upper lumbar, right? So T12 is the first affected vertebra in pot spine, in case of pot spine. Most common site for abdominal tuberculosis. Mid part of the ileum, jejunum, cecum, or none of the above. Which is the answer? Why cecum is the answer? So why ileocecal junction is the most commonly occurring site for TB? Stricture formation is যে কোনো জায়গায় হতে পারে, জেজুনামে stricture formation হতে পারে, that is a complication of TB. But আমি জিজ্ঞেস করছি যে why it is most commonly primary abdominal tuberculosis, কেন ওখানে বেশি হয়? ন্যারো জায়গার সঙ্গে কি সম্পর্ক আছে? Because abundance of lymph node, lymphatics at that site. So mostly abdominal tuberculosis is via the lymphatics or hematogenous route. So abundance of lymph node যেখানে বা lymphatics যেখানে হবে সেইখানেই abdominal tuberculosis বেশি হবে। তো ileocecal junction, cecum, and terminal part of the ileum, they are the most common sites. Which is the most specific ophthalmoscopic finding in miliary tuberculosis? Papilledema, choroid tubercle, iritis or uveitis? Which is the most specific finding ophthalmoscopic? Choroid tubercle. This is the most important and most characteristic finding of miliary tuberculosis. So, in each and every case of miliary tuberculosis patient, you must have do an ophthalmoscopic examination to find choroid tubercle, to find papilledema. But the choroid tubercle is the most specific one in case of miliary TB. The most common type of tuberculosis in people living with HIV, especially in case of CD4 more than 200. Is it disseminated tuberculosis or miliary TB? Is it extra-pulmonary TB? Or is it or none of the above? In case of people living with HIV, CD4 more than 200. This is the main important point. CD4 more than 200. No, none of the above. Because in case of PL-HIV with CD4 more than 200, that means his immunity is not much lower. So that simulates like the secondary tuberculosis. Pulmonary tuberculosis is the most common. Secondary tuberculosis being cavitary lesions and consolidations also. But in case of CD4 less than 200, the immunity is pretty much lower. So extrapulmonary tuberculosis, disseminated tuberculosis. Now let's discuss today's topic. Today's topic is diagnosis and investigation of tuberculosis. First of all, so this is a mycobacterial disease. So the easiest way to identify TB is by direct microscopy, by demonstrating acid-fast bacilli. This is the easiest method. So first you have to learn how to collect a specimen and what would be the most important and most correct specimen for tuberculosis diagnosis. So the most commonly collected specimen is sputum, but in case of, especially in case of pulmonary tuberculosis, in case of EPTB, extrapulmonary tuberculosis, you cannot, but there is a norm that you must have to do a sputum examination in all case of EPTB, but this is not the pathognomic. The pathognomic sputum positivity would be in secondary pulmonary tuberculosis. So ask the patient to cough out properly. The sputum must be mucopurulent, not salivary, not mucoid, and preferably not mixed with blood or any food particles, because blood, if the patient gives you blood stained sputum, then in microbiologist can falsely identify the blood particles as acid-fast bacilli, because they resembles as like acid-fast bacilli under microscope. So the sputum neither be blood stained or not saliva. And what would be the ideal time of sputum collection? Early morning. Why it is early morning? Why it is early morning? Actually, fasting state, because of fasting state. Fasting state না হলে যদি ফুড পার্টিকেলস চলে আসে তাহলে ফলস একটা আইডেন্টিফিকেশন আসবে। So 2 consecutive days sputum sample. Ask the patient to give a sputum sample on the day of arrival to the OPD at that time, and the next day morning, early morning sputum. There was a norm in around 15 to 20 years back that they could collect the 3 consecutive day sputum samples to diagnose TB. But nowadays NTP and WHO also recommends to do only 2 samples, the spot and the next day early morning sample. Patient who cannot expectorate, patient are having dry cough, they cannot expectorate. So what may be the way out to collect the specimen? The bronchoalveolar lavage is the last thing. First thing you have to do, induction of the sputum. How to induce? You ask the patient to sit on a preferable site and firstly nebulize the patient with a SABA, short acting beta bronchodilator, followed by nebulize the patient with hypertonic saline. So hypertonic saline, after nebulization of the hypertonic saline, do a chest physiotherapy. Then patient may expectorate. But mind it, don't collect saliva. Always mucus or mucopurulent expectoration. And if the patient cannot expectorate after the induction of the sputum, then the bronchoalveolar lavage would be the better option. In case of children who frequently swallow their sputum, the most vital investigation is to do a gastric lavage, but the yield is lower than that of the direct sputum microscopy. In case of EPTB, extra-pulmonary tuberculosis, as I have already mentioned, in conjunction with the sputum microscopy, you have to do the site specific or the symptom specific investigation. Like in case of CNS TB or TB meningitis, you have to do a CSF study, CSF microscopy or CSF CBNet. In case of pleural fluid investigation, you have to do a pleural fluid test. The marker of the pleural fluid or any kind of ascitic fluid or pericardial fluid, pericardial tuberculosis, the marker of the tuberculosis are, it should be lymphocytic, it should be exudative, and the ADA level will be higher. So I will discuss later on. And only in case of empyema, there is the pus in the pleural space, you can find AFB in direct microscopy, not in other types of pleural effusion. Because ADA, adenosine deaminase, এটা আমি পরে আসবো, আমি ডিসকাস করবো এটা নিয়ে, ঠিক আছে? তো only in case of empyema or pus in, if you microscopy the pus, if you give do a slide from the pus of the pleural space, then you can find some AFB. But if there is no pus or no empyema, only sterile pleural fluid, this is because of the type 4 hypersensitivity reaction, pleural effusion. This is not a direct invasion of the bacilli. So you may not find any bacilli under microscopy in a sterile fluid. Lymph node aspiration by or FNAC and tissue biopsy. So these are the sites from where you can diagnose or microscopically identify the bacilli. After collection of a proper specimen, you should prepare the specimen. First, you have to decontaminate and concentrify the specimen, because in case of expectorated sputum, there may be many commensal floras. So this can be misinterpreted as AFB. So it must be decontaminated and concentrated. There is a method called, microbiology is a পড়েছিস, Petrop's method, and there is another method called modified Petrop method. So Petrop's method is sputum decontamination methods that isolates microbacteria and kill the oral commensal bacteria present in the specimen. So the sputum transfers to a sterile test tube, followed by adding sterile 4% NaOH, which kills the commensals, and then the tube incubated at 37 degrees centigrade for 30 minutes. Then the mixture to be centrifuged at 3000 RPM for 30 minutes and the supernatant poured off. So a modified Petroff's method involves stopping the digestion process by diluting the sample with water before the NaOH mount. After the preparation of the specimen, you should go for Zn staining or fluorescent staining. So this is the Zn staining procedure. You know better than me. What is the procedure? Zn staining? একজন যে কোনো একজন বল, যে কোনো একজন বল, হ্যান্ড রেস কর, বল যে জেন স্টেনিং জানিস। দিস ইজ ইম্পর্টেন্ট। মাইক্রোবায়োলজিতে পড়েছিস মানে এখন তো ভুলে যাবি না। বল কি করতে হয় ফার্স্ট, বল। হ্যাঁ, ফার্স্টে কি করবি? স্মিয়ার প্রিপেয়ার করলি from the purulent portion of the sputum. Purulent, not the mucoid portion of the sputum. Purulent portion, ঠিক আছে? Next, carbolfucsin, then heat fixation, then acid alcohol to decolorize, then methylene blue application, then next is fluorescent staining. Fluorescent staining is somehow better than that of the Zn staining, because in case of in Zn staining, the acid fast bacilli, so there are many caveats of AFB staining, AFB Zn staining. As I have already mentioned, there are many acid fast bacilli, acid fast organisms rather than. So in case of hemoptysis, it may falsely interpreted as acid fast, but in case of fluorescent staining, these caveats may be overcome. So we generally use auramine or rhodamine stain. This procedure you should not memorize. This is a very long procedure. Then culture medias. So what is the most important and appropriate culture media of tuberculosis, of Mycobacteria? LG media, Lowenstein-Jensen media. So it is a broth. So LG media takes 6 to 8 weeks to get a culture result. The colony character of the Mycobacterium tuberculosis is often dry, rough and raised colony. This is called as eugonic growth. And in case of non-tuberculous Mycobacteria, the growth is dysgonic. This is smooth colony. So this is a colony. This is a colony. LG media. And there are some automated medias. This is the recent advance. So two automated medias are Bactec MGIT and Bacti-Alert. So the mechanism of Bactec MGIT, as I have discussed in my previous class, that it uses Middlebrook broth which have a fluorescent media, and that fluoresces following the oxygen reduction induced by aerobically metabolized bacteria. So this is the aerobic bacteria, Mycobacterium tuberculosis. So it uses oxygen, that is indicated by Bactec media. Growth is indicated by Bactec media. And in case of Bacti-Alert media, the liberated carbon dioxide is indicated by a colorimetric pH change method. But the turn around time of these two medias are also 6 weeks. This is not less than 6 weeks. So in case of culture methods, this is the culture method is the gold standard investigation for tuberculosis identification, Mycobacterium tuberculosis. So in case of all conventional and automated medias, the microbiologist usually give you result at 2 weeks interval. 2 weeks interval, first 2 weeks, second 2 weeks and next 2 weeks. If in between 2 weeks culture any of the culture grows any signals of mycobacteria, then they will inform you. So National Tuberculosis Elimination Program recommends sputum smear examination for to identify pulmonary tuberculosis, to assess the activity of pulmonary tuberculosis. If the patient is sputum positive and he is not under treatment, is active, this is active tuberculosis and he can spread. Follow up of tuberculosis, anti-tuberculosis treatment. So the schedule of sputum smear examination is after IP and after CP, intensive phase and continuation phase, after 2 months and after 6 months of the completion of the treatment. And post treatment there is new guideline that you should follow up the patient with sputum smear examination after 6 months, 12 months, 24 months and 48. To assess the treatment response, if you find that after 2 months of ATD the sputum smear is positive, then there may be a chance of treatment failure. Then you should assess whether the patient is having any drug resistant tuberculosis or not, and also you should check the compliance of the ATD. If the patient is taking the anti-tubercular drug properly at proper time, also the infectivity of the tuberculosis patients. So this is the gradation of the AFB. You already know from your microbiology class. So this is Jaden staining. Okay. The fluorescent staining method is, fluorescent staining chart is different. This is not the fluorescent staining chart. So according to the culture media, according to the culture time, the Mycobacterium can be classified into rapid grower and slow growers. So this is the Mycobacterium population other than the tuberculosis. If the specimen is rapid grower, that means the specimen grows less than 7 days. And in case of slow growers, the specimen grows more than 7 days. For more than 7 days, the MTB, MTBC and M. lepri are the in slow grower group, and as it takes 6 to 8 weeks. But in case of rapid growing mycobacteria, the most noticeable organisms are Mycobacterium abscessus, Mycobacterium chelonia and fortuitum. So Mycobacterium, these chelonia, abscessus and fortuitum regularly do not cause any pulmonary involvement. They rarely cause pulmonary disease, but occasionally and frequently they cause extra-pulmonary TB. The most commonly encountered extra-pulmonary TB are lymph node tuberculosis by them, and skin tuberculosis, skin ulcer by Mycobacterium abscessus. Slow growing mycobacteria, most important organisms are Mycobacterium meridum and Mycobacterium ulcerans. So Mycobacterium meridum causes swimming pool granuloma. This is a different granuloma, type of granuloma, and these organisms, Mycobacterium avium complex and Kansasi, these organisms frequently causes pulmonary tuberculosis, just like Mycobacterium tuberculosis. So what are the drawbacks of sputum smear examination as a first line investigation? What do you think? What may be the drawbacks? Properly নেওয়া হয়েছে, মিউকয়েড পুরুলের নেওয়া হয়েছে, তাও কি কি ড্রব্যাক থাকতে পারে? হয়ে গেছে ট্রান্সপোর্ট হয়ে গেছে, মাইক্রোস্কোপি তলায় আছে, সব ডায়াগনোস হয়ে গেছে, তাও কি কি ড্রব্যাক থাকতে পারে? হয়ে গেছে, আমি বললাম মানে জাস্ট মানে ইউ হ্যাভ আইডেন্টিফাইড দ্য অর্গানিজম, বাট তাও কি কি ড্রব্যাক থাকতে পারে? বিকজ আমি বললাম আগে না, there are many acid first organisms. Whether this is a TB, Mycobacterium tuberculosis or not, you cannot be certain from the microscopy, right? So if the patient is having hemoptysis and nocardiosis along with tuberculosis cannot be identified alone by the microscopy. Next, proper staining now hote pare. Third is in case of non-tuberculous mycobacteria, this signals also as a acid first bacilli. NTM is also as acid first bacilli, but this is not a tuberculosis, Mycobacterium tuberculosis. So to differentiate between non-tuberculous mycobacteria and Mycobacterium tuberculosis, culture method is the gold standard, followed by CBNAT, molecular methods or TrueNAT. And also sputum smear examination always may not be positive for paucibacillary cases. Like paucibacillary cases means less number of bacilli. So কাদের এটা হতে পারে? Immunocompromised individual, people living with HIV যাদের আছে তাদের কিন্তু paucibacillary organism থাকতে paucibacillary হয়. Also it cannot differentiate between drug sensitive or drug resistant cases. No role in EPTB and maybe false positive in certain cases. So the next important method is molecular method of identification of TB, Mycobacterium. This is currently WHO and NTP endorsed first line investigation in case of all presumptive tuberculosis and extra-pulmonary tuberculosis patients. What are the types of molecular methods? PCR is the important molecular method. Molecular method, যে কোনো molecular method এর mechanism জানিস? একটা idea আছে কোনো molecular method কিভাবে কাজ করে? Like PCR, how do it act? Right, the amplification of the cut short of the DNA fragment, তাই তো? এটার জন্য এটা দিয়ে আইডেন্টিফাই করে, same as of the PCR, CBNAT. Next is, so first is PCR, second is cartridge based nucleic acid amplification test, TrueNAT, LPA, LAMP. So these are the most important molecular methods. Follow the chart. This is the NTP chart. If a patient if you suspect a presumptive, what is presumptive tuberculosis? What is presumptive tuberculosis? What are the symptoms of presumptive tuberculosis? কি করে একটা পেশেন্টকে বলবি যে this is a presumptive? Cough and cold. So rhinorrhea is cold. এরা একজন কিছু বুঝতে পারছে, সবাই বললে কি করে বুঝবে? একজন বল, তুই বল। নাইট সোয়েট তো অনেকেরই থাকতে পারে না, লিম্ফোমা পেশেন্টের নাইট সোয়েট হয়। বি স্পেসিফিক কি হবে? মোর দ্যান 2 weeks, কাফ and fever and cough for more than 2 weeks. This is a presumptive tuberculosis. And also if a patient is in contact with a sputum positive case. So in case of all presumptive tuberculosis, you must have to do sputum microscopy and CBNAT, be it a TrueNAT or CBNAT. CBNAT is a type of qualitative nested PCR which purifies and amplifies the nucleic acid of the organism. আর একটা রিসেন্টলি CBNAT করা হয়েছিল besides tuberculosis, রিসেন্টলি কিসে জানিস? CBNAT ইউজ করা হতো, TrueNAT ইউজ করা হতো রিসেন্টলি 2 বছর আগে। আমরা একটা প্যান্ডেমিক গেলাম, কোভিডে করা হতো এটা। কোভিডে এনপি সোয়াব নিয়ে TrueNAT or CBNAT আমরা করতে পারতাম এটা। What is the benefit of CBNAT along with the microscopy? allowing the identification of the so it amplifies specific RPOB gene which is responsible for the rifampicin resistance or rifampicin sensitivity. So rifampicin resistance can also be diagnosed with the CBNet. So that's why this is the first line investigation of choice. Because India te এখন there is a lots of cases of undiagnosed MDR or rifampicin resistance cases. That's why this is the first line investigation. Result within 2 hours. And what samples can you use for CBNet? First is sputum. Next is BAL fluid, bronchoalveolar lavage fluid, pleural fluid, CSF, biopsy material, and not used, cannot be used, urine, because and blood, yes, blood and urine, they cannot be used as a specimen for CBNet. So there is a tube called Falcon tube in which you should collect the CBNet sample, must be 2 ml, 2 to 5 ml. After collection of the specimen, transfer 2 ml of the material inside the cartridge, and cartridge inserted into the test platform, followed by it is automatically filtered and washed, then ultrasonic lysis of the DNA and release of the DNA, and then amplification of the DNA particle by PCR method. So CBNet এর report যখন আমরা দেখব তখন কিভাবে আসে? CBNet report has 2 parts. First is the presence of the organism MTB, মানে দুটো পার্ট থাকে, MTB positive or negative, found or not found. Next is rifampicin resistance, found or not found. Okay. So this is the benefit of CBNet. But what CBNet cannot be used as an follow-up investigation because DNA releases from dead bacilli also. So you cannot determine from CBNet if the patient is CBNet positive after 2 months. That doesn't mean that the patient is in active tuberculosis. Okay. Line probe assay. You have heard the term line probe assay. কি প্রিন্সিপালটা কি, মানে অ্যাকচুয়ালি প্রিন্সিপাল ইজ সেম অ্যাজ অফ পিসিআর, বাট এখানে ডিফারেন্সটা কি ফ্রম দ্য CBNet? হ্যাঁ বুঝতে পারছি না কি বলছিস, দাঁড়িয়ে বল কি বলছিস। আচ্ছা ঠিক আছে, তো লাইন প্রোব আছে CBNet এ কি দেখি? CBNet এ অনলি রিফাম্পিসিন সেনসিটিভ অর রেজিস্ট্যান্স, বাট লাইন প্রোব আছে করতে গেলে আমাকে করতে হবে কি, the sputum or the specimen must be positive, microbiologically positive or culture positive. And there are 2 types of LPA, FL-LPA and SL-LPA, first line LPA and second line LPA. First line LPA means it detects the resistance of isoniazide and rifampicin, and the second line LPA means it detects the second line drug sensitivity like fluoroquinolone and other, and amikacin also. সবকটা ডিটেক্ট করতে পারে না, 3টে ড্রাগ ডিটেক্ট করতে পারে, তার মধ্যে একটা হচ্ছে ফ্লুরোকুইনোলোন। বিকজ the target gene, genetic target for the primary, the first LPA, first line LPA is INHA and CATG and RPOB. RPOB for the rifampicin and INHA and CATG gene for the isoniazide. And in SL-LPA, GYRA, RRS and MB gene. GYRA, gyrase, GYRA means gyrase, gyrase is for fluoroquinolone, and EMB gene for ethambutol. Next is LAMP, loop mediated isothermal amplification. The mechanism is same as of CBNAT. This is a kind of PCR, but this is a NAT test and this is a rapid test. Then lipoarabinomenon test. So you all know that the lipoarabinomenon is an important ingredient of the cell wall of the Mycobacterium. So it can be detected from urine LAMP test. This is called urine LAMP test. This is a point of care test, this is a rapid test and screening test as well. Now latent TB. What is latent TB? What is this microbiology? What is latent TB? Any idea? Right. So if we consider the pathogenesis of the Mycobacterium tuberculosis, আগে পড়েছিলাম pathogenesis দুটো পার্টে হয়. First, the patient is infected. Later on, it might progress into a disease. So in that medium part, if the patient is infected but that is not progressed to a disease, that is latent TB. So latent TB is inactive form of tuberculosis. That means that the patient contained tubercle bacilli in his body but is not infectious and is not producing any disease. So chest X-ray finding, sputum examination does not reveal anything. Also there will be no symptom. But there are certain risk factors in case of LTBI, latent TB infection can progress into an active tuberculosis. কি মনে হচ্ছে কি হতে পারে? কি হতে পারে? একটা পেশেন্টের ধরে ছিল, মানে আমাদের বেসিক্যালি সবারই কম বেশি LTBI আছে, কারণ আমরা অলরেডি উই আর ইন এ টিবি এন্ডেমিক স্টেট, ইন টিবি এন্ডেমিক কান্ট্রি। সো আমরা সবাই এক্সপোজড, আমাদের এখন টেস্ট করলে হয়তো LTBI পাওয়া যাবে, কিন্তু আমরা কখন বা কোন সিচুয়েশনে আমরা অ্যাক্টিভ টিউবারকুলোসিসে চেঞ্জ হতে পারি? রাইট, ইমিউনোকম্প্রোমাইজ স্টেট, prolonged steroid use, chronic kidney disease but requiring dialysis. Not all chronic kidney diseases. People living with HIV, drug abusers and uncontrolled diabetes mellitus and other types of immunocompromised state. Also patient having recently contacted with sputum positive tuberculosis patient. And children less than 5 years. So what are the methods to diagnose LTBI, latent tuberculosis? জানিস, কোনো জানা আছে কিছু latent tuberculosis কি করে ডায়াগনোস করে? মাইক্রোবায়োলজিতে পড়েছিস তো? You have heard the name of Mantoux test? What is Mantoux test? What is the mechanism behind the Mantoux test? কিরে ওদিকে কারা বসে আছে? ওগুলো তোদের ব্যাচই তো? এই ব্যাচের স্টুডেন্ট? কি পড়াচ্ছি বলতো? আগের স্লাইডটা কি ছিল? উঠে দাঁড়িয়ে বল। পড়তে আসিস তো? মানে কি, মানে শিখতে আসিস না আসবি না? কি মনে হচ্ছে? এরম করলে কিন্তু তুই নিজেই শিখতে পারবি না, আমার কিছু যায় আসে না, আমি পড়েই চলে যাব। কি করতে এসছিস? ডাক্তার হতে এসছিস তো? তাহলে এরকম করে গল্প করছিস কেন? সামনের বেঞ্চে আছে, এখানে চারজন, এখানে। LTBI diagnosis methods of আর Mantoux test. Mantoux টেস্টের কি প্রিন্সিপাল বললি? হ্যাঁ, প্রিন্সিপালটা কি, মানে কি করব? পিউরিফাইড প্রোটিন ডেরিভেটিভ কোড দেবো, তারপরে অলরেডি টিবি থাকলে হাইপোথিসিস হবে না, ডায়াগনোসিস করব কি করে? ইয়েস, সো মেকানিজম কি? 0.1 ml 2 tubercular unit, not more than this. মোস্টলি আমরা যেটা দেখি, মানে আমাদের গভর্নমেন্ট সেটআপে 2 টিউ থেকে 5 টিউ দিয়ে আমরা টেস্ট করি, বাট তুই যদি বাইরে প্রাইভেটে কাউকে একটা মান্টু টেস্ট করাস তাহলে দেখবি ম্যাক্সিমাম জায়গাতে 5 টিউ বা তার উপরে দিয়ে টেস্ট করে। যখন মান্টু টেস্ট করতে দিবি কোনো পেশেন্টকে, অলওয়েজ মেনশন দ্যাট ইট মাস্ট বি 2 টিউ, নট 5 টিউ। বিকজ যদি কি মেকানিজমটা কি, আমি 2 টিউ দিয়ে পিপিডি, পিউরিফাইড প্রোটিন ডেরিভেটিভ আমি ইনসার্ট করছি সাবকিউটেনিয়াস স্পেসে, তারপর কি করব, তারপর মেকানিজমটা কি, মানে কিভাবে আমি করব, প্রসিডিওরটা কি। দেখ এই যে ইন্ট্রাডার্মালি পিপিডি আমি দেবো 0.1 ml 2 টিউ পিপিডি, RT23 পিপিডি স্ট্রেন নেম RT23। দেন ফার্স্ট ওই জায়গাটাকে মার্ক করতে হবে থ্রু এ পেন অর এনি স্কিন মার্কার। রিডিং আফটার হ্যাঁ 2 আওয়ার্স, 2 আওয়ার্স কি করে দেখবি, 72 hours, 48 to 72 is the window, but preferably do it after 72 hours. কি মেজার করব, ডায়ামিটার অফ দ্য ইনডিউরেশন, ডায়ামিটার অফ দ্য ইনডিউরেশন। এখানে একটা ওখানে ধর দিলি তুই, তারপর একটা আলসার হতে পারে, বাট আমি আলসারের বেস মেজার করব না, I have to measure the induration size of the induration. তো mechanism of the Mantoux test 0.1 ml আমি দিলাম 2 টিউ, তাহলে তারপর কি হবে বল, this is a antigen, RT23 is a antigen, purified protein derivative, it is a antigen, so antigenটা গেল, তারপরে ইন্টারফেরন গামা বা এইগুলো রিলিজ হতে থাকবে, ওইগুলোতে অ্যান্টিবডি, আরো অ্যান্টিবডি আসবে, টাইপ 4 হাইপার সেন্সিটিভিটি হবে, দিয়ে ওখানে একটা ইন্ডিউরেশন ক্রিয়েট হবে। সো দিস ইজ দ্য মেকানিজম। আমাকে কি দেখতে হবে না, আমাকে দেখতে হবে কি যে কত কম দিয়ে, মানে আমি ধর 2 টিউ দিচ্ছি, মানে কি দিস ইজ দ্য লিস্ট অ্যামাউন্ট অফ অ্যান্টিজেন আই এম ইনসার্টিং। সো লিস্ট অ্যামাউন্ট অফ অ্যান্টিজেনে যদি রিঅ্যাক্ট করে, সার্টেনলি দিস ইজ পজিটিভ। বাট আমি যদি আমি ধর 2 টিউ থেকে 5 টিউ করলাম, 5 টিউ থেকে 10 টিউ করলাম, 10 টিউতে করলে কিন্তু আমাদের সবার পজিটিভ আসবে, বিকজ আমাদের 10 টিউতে পজিটিভ আসবে, কারণ আমাদের তো সিএমই ওই রকমই। কিন্তু আমাকে দেখতে হবে আমার শরীরে যদি ব্যাসিলাই নাও থাকে, তাও 10 টিউ দিয়ে পজিটিভ আসবে, because of the CME, we have a strong CME, we have a strong cell mediated immunity. But যদি 2 টিউতে পজিটিভ আসে, that means the patient is having latent TB. 10 টিউ দিয়ে পজিটিভ, 10 টিউ দিয়েও যদি নেগেটিভ আসে, ধর 10 টিউতে কারো নেগেটিভ এলো, that means that cell mediated immunity is depressed. So 10 টিউ always uses 10 টিউ not to diagnose latent TB, but to diagnose sarcoidosis, because in case of sarcoidosis CME weakens. সো সেল মিডিয়েটেড ইমিউনিটি যদি উইক হয়ে যায়, তাহলে 10 টিউ দিয়ে আমি যদি করি, তাও কোনো ইনডিউরেশন পাবো না। ঠিক আছে, যখনই করতে দিবি বাইরে কোনো পেশেন্টকে মান্টু টেস্ট, অলওয়েজ মেনশন দ্য টিউ, 2 টিউ, রাইট। Induration is measured as more than equals to 5 millimeter or more than equals to 10 millimeter. If the induration is more than equals to 5 millimeter and the patient is having HIV or recent contact with active TB or any sort of immunocompromised state, then he can be stamped as LTBI. And in normal patients, if the induration is more than 10 to 15 millimeter, then he or she cannot be diagnosed as LTBI patient. Next is interferon gamma release আছে, IGRA. This is a newest method of identification of the LTBI. So এখানকার মেকানিজম কি, মানে এর তো মান্টু টেস্টের মেকানিজম কি, অ্যান্টিজেন দিলে এখানেও ইন্টারফেরন গামা রিলিজ হয়, তো এই ইন্টারফেরন গামাই তো ইন্ডিউরেশন ক্রিয়েট করে। বাট দিস ইজ এ টেস্ট অফ ইন ভিভো, মানে পেশেন্টের বডিতে করা হচ্ছে, বাট দিস ইজ এ ইন ভিট্রো টেস্ট, IGRA ইজ এ ল্যাব টেস্ট। তো এখানে কি হয়, এখানে পেশেন্টের ব্লাড কালেক্ট করে সেটাকে তোর, দেখ এখানে একটা পিকচার আছে, দিস ইজ এ টি সেল, সো দিস ইজ এ অ্যান্টিজেন প্রেজেন্টিং সেল, AMTB binds with the antigen presenting cell and then binds with the T cell, CD4 T cell. So তারপরে এই মেজারমেন্টের পর এখানে রিলিজ করে ইন্টারফেরন and TNF alpha which causes induration. But same principle can be used in interferon gamma. There are two types of interferon gamma: Ellis spot or T spot test and quantiferon test, quantiferon TB test. সো এখানে কি হয়, এখানে হচ্ছে ব্লাড স্যাম্পল নিয়ে দুটো টার্গেট দেওয়া হয়। এখানে তো টার্গেট অ্যান্টিজেন ছিল ওই 2TU PPDটা যেটা আমি দিয়েছি, তার অ্যান্টিজেন। এখানে অ্যান্টিজেন in case of IGRA, antigens are different. ESAT6 and CFP, these are the two specific antigens we use generally in IGRA. So এটার বেনিফিট কি, আমি interferon gamma is why more preferable than MANTU, because in case of MANTU test, if the patient is BCG vaccinated in recent past, may be false positive, because BCG is the antigen and the antigen we use in MANTU same RT23, ওখানে BCG তে ইউজ করা হয়। RT23 দিয়ে ওটারই তোর সেরো পজিটিভিটি। তো এখানে ইগ্রাতে কিন্তু আমরা ইউজ করি ESAT6 and CFP10. This is specific for Mycobacterium infection. This is not cross-linked with the BCG vaccination. Then these all are the molecular methods of identification. Radiology. So this is what type of tuberculosis? This is আগের ক্লাস করিসনি তাহলে কেউ বলতেই হবে। এটা এক্সামে দিয়েছিলাম, তোদের এমসিকিউ এক্সামে আমি দিয়েছিলাম কোশ্চেনটা। এটা কি রে? দিস ইজ এ লিম্ফ নোড, দিস ইজ গনস কমপ্লেক্স। আমি তো এতবার বললাম এটা, দিস ইজ এ গনস কমপ্লেক্স। দেখ এটা লিম্ফ নোড তো, ওই তো হাইলার লিম্ফ নোড তো। This is, so this is a primary tuberculosis and this is secondary TB. Why? Yes, this is upper lobe involvement and this is a cavitation. This is, এটা কি, এটা এক্সট্রা ক্লাস করেছিস তো? What is this? This tuberculosis pleural effusion, but আমি এটা ধরলাম tuberculosis pleural effusion. And this is abscess. আমি কতবার বলেছি this is abscess, this is a air fluid level abscess. This is miliary TB. This is a millet shaped nodule. This is a millet shaped nodule. Okay, this is and the distribution of the miliary TB is homogeneous but more on the lower lobe. And this is brain city. This is tuberculoma, CNS tuberculoma. Next, extra-pulmonary TB. So কি আছে? ক্লিনিক্স আছে? ও ঠিক আছে।